Medical Student Association welcomes our keynote speaker, Dr. Mark Bleiweis. He received his medical degree at the University of California, San Diego. He completed his residency at the University of North Carolina at Chapel Hill. Following his residency, Dr. Bleiweis completed a fellowship in pediatric cardiothoracic surgery, where he trained under Dr. Frank L. Hanley. In 2005, he joined the University of Florida as the director of Congenital Heart Center.
So that's kind of the training. You know, in practice, just to give you an idea of the breadth of what we do, I operate on all sorts of congenital heart diseases, and that includes things like holes in the heart, where parts of the heart never developed. A lot of the things I do treat things where parts of the heart just didn't develop well. So kids can be born, a large portion of kids we treat are born with one side of their heart not developing. Things like hypoplastic left heart syndrome, where the left side of the structures don't develop, so they don't have the ability to pump to the body. So we have to figure out how, over basically 3 surgeries over about 3 to 4 years of their beginning of their life, to try to make the best out of the situation. And so many of those children need transplant. So that's one kind of problem we deal with. We deal with kids and young adults with heart failure. Right now in our hospital we have about 7 children and young adults who are waiting for heart transplantation, just in the hospital right now. We have a child who is about 9 pounds who has artificial heart pumps sitting outside the body connected to him inside to basically do the work of his heart, since his heart has completely failed. And so he is waiting for transplantation. And that's the bedside I just left to come over here. It's an interesting array of problems I deal with, and it's no exaggeration. It's life and death every day in our unit. It's life and death every day in our floor. And the great thing about it is most of the time, almost all the time, it turns out really good. And so we have about a 90. We have one of the highest survival rates in the country here. It's about 98%, and that's all comers. Yeah, the question was how healthcare reform will affect cardiothoracic surgery. Well, I think it's already affected. There's a lot of factors that have affected cardiothoracic surgery, and actually there are fewer and fewer people going into cardiothoracic surgery because the reimbursement with all the reforms has gone way down. So that about 3, 4, 5 years ago, cardiothoracic surgery programs stopped filling. When I was applying, there were 3 to 1 applicants for every spot. Now we can't even get applicants to fill all the spots. There's not enough applicants to fill all the spots. So, and part of that is reimbursement's gone way down. So people think, why should I train for 10 years or 9 years or 8 years, and then you're not going to make a living to cover what you've spent to get there. Many of us have a lot of loans, and it's costly. You spend a lot of time still working and taking a lot of risk. So I hope that will get better. I know that the board and our major groups, the committees we participate in, we're trying to make changes in the way we train people so that it makes it more palatable. And one of the other things they're trying to do is try to attract more women into cardiothoracic surgery, because that has not been addressed. But it's mostly, I think reimbursement's really hurt us.
When you're dealing with a new patient, do you ever try to create a new method to put them on and perform the surgery? And do you work on a team when you're trying to come up with this method of what procedure you're going to take on with them over the years? Yeah, so we have it is a team-oriented approach. So we have multi-disciplinary conferences, and we talk about each case. And so we present each case, and then we talk about what we would do and what the options are. And we have come up with, new procedures here, and we've broken a lot of ground here. But yeah, we talk about all the cases as a group, and we even teleconference with other centers. If we like, for example, our center in Jacksonville, we'll teleconference so we can have a joint group discussion. Would you ever consult a biomedical institute? Would you ever go outside the medical field to search for a new method that you could use?
Oh yeah, and we search. I'll give you a good example. We collaborate with engineers, physical therapists with interest in diaphragm function, for example. We have a lot of children and adults who stay on the ventilator for a long time. And as they stay on the ventilator, the diaphragms start to weaken. Like any muscle, they start to atrophy without use. And so there's a physical therapist, PhD physical therapist, who's interested in diaphragm function. So I asked him what his thoughts were about training our children. He developed a little training device for adults, and I said, can we extrapolate that and do it with our children? So he modified, and we modified some things, and we were able to train our children and train their diaphragms to get them stronger and wean kids from the vent. Such that now it's stimulated a larger protocol, and hopefully for us, a grant to get NIH funding to support it. So, yeah, we collaborate with engineers, therapists, and other experts. Pharmacists are another great, pharmacologists.
Are you aware of any differences in ethical issues that you face dealing with the pediatric cardiovascular rescue rather than the adult cardiovascular? Are there any different ways that you approach each case because they're physiatric?
Yeah. Well, there's this, the Gestalt, and I take care of kids and adults. Kids, it's always there's definitely we approach things differently. So an example, transplantation. I can tell you that there's always the ethical issue of there's the lack of donors, so you have a resource issue. So how do you allot organs? How do you choose which patients you'll give a heart to and which patients you won't? I think we tend to be, and I know in our group, we tend to be much more lenient on the children's side than an adult service would be. So that may be considered an ethical dilemma. Some people would say, well, how can you use this resource differently when it's the same resource? But for me, it's always hard to choose which, how do I determine which child should have something done versus another? So another example, dealing with genetic syndromes, taking care of that provides some with ethical dilemma, provides me with no ethical dilemma. I've had many. One recently, I'll tell you a few. One recently was the smallest baby that we've operated on here. It was a less than 3 pound baby, 1.2 kilograms, where we reconstructed the baby's aortic arch. And the other area we have a great experience here, and it was the heart assist devices. I don't know if you know what the ventricular assist device is. It's a pump, and it's like a little artificial ventricle, and it receives the blood from the heart, and then it pumps it out to either the right side or the left side. And most of the time here we put 2 pumps in, one on the right and one on the left. And we had usually it's the kind of situation where a child like one about 2 years ago presented, normal child, on a soccer team, and goes to the pediatrician, they say, oh, you have pneumonia, and then the kid goes home, and mom and dad say, you're not getting better, and she was sleeping in bed when her feet were ice cold, and just wasn't moving, and so we took her back to the ER, and the next thing they know, their kid doesn't have pneumonia, their child has, profound pulmonary heart failure, and they're being flown to Gainesville, and in coma, and we took a gamble and put artificial heart in that patient, and that patient, she woke up completely, and about 5 months later, I transplanted her. And I wish I could pull it up, but there's a YouTube video. If you look up Grayson's song, Gracyn, Grayson singing, or type in that and look at YouTube, and she's singing in church about 2 weeks after leaving the hospital after a transplant, and it's amazing. And I think that's still true. It's a hard road. For me, it's the only thing I could see myself doing in medicine. But I'd say the most important thing is find what you love to do. Find what you love to do, and it won't be work. I love what I do, and I think if you were to come around and watch me do it, you'd know I love it, and it's do something that keeps you challenged and excited to be there. Because so the question is neonatal surgery, and does it pose problems with attachment? Yes, I think it's really, for me, this is for me, it's hard for me not to get attached to these people and these kids.
it is, but I think that's a great part about it too. So when things go really well, it's awesome. When things don't go well, it can be really, really hard. When I first started, it was very hard when we lost a patient or we had a major problem. Even if we knew it wasn't because of what we did, it was really hard, and I used to really rethink if I could do it. It was because of that emotional part of it. But you know, for me now, it's still hard, but the recovery is quick. It's not as you have to be professional. You have to do this. And so the way I justify it is that if I don't do it, then someone else is going to have to do it, and I'm pretty good at this. I take good care of these people. And so I need to be doing it. That's basically what you said. Oh, they're up in the bleachers.
I was wondering, do children and infants who have cardiothoracic surgery, do they generally have any long-term limitations
Yeah.
in terms of like, are they replaceable, or I guess depending on surgery, or shorter lifespans or anything like that?
Well, it's definitely specific to like different heart problems. So I can tell you that kids with, say, hypoplastic left heart syndrome, yes, we can say if they have one ventricle, they have a shorter lifespan. But there are certain problems that they can lead a absolutely normal, healthy life and have a normal lifespan. As far as like sequelae after surgery, we're starting to recognize, because the first thing we had to solve was keeping kids alive. So once they solved that, then they started looking at how you can optimize their long-term function and quality. Because we noticed a lot of kids were having neurologic issues. So things like seizures, learning disabilities, attention deficit. So there's been a growing interest in that, and we're actually still in the midst of understanding that and altering the way we do surgery, the way we take care of them before surgery and after surgery to try to optimize those issues. But it's very lesion specific.
What care you think is necessary for a child, and the care that the parents need is best for them?
That's a great question. All we can do is, I understand that they're the final decision maker. There's no question. They have to make the decision. We have to present them with as much, detail and facts, and then give them their options. And there are times when, they may not agree with us, and then we have to have a pretty frank conversation with them as a group. We'll have a family meeting with multiple physicians, nursing staff, social worker, clergy, whatever. And we'll put everybody in a room and basically bring the issues up. It's like any other, kind of conflict resolution. You got to get everybody in there to try to communicate. Most of those issues are just communication issues. And so I'm quick to bring them all in a room and talk to them. And usually we don't get to that point, because one of the things you'll learn as a physician is the most important thing you can do is communicate with your patients. If you rush in and rush out, you will have problems. More lawsuits happen because you didn't communicate well. And if you just sat down with the families and literally sit there, even if it's for a few minutes, they think you're there for a long time. So it usually doesn't get that far because we're communicating with them every day. We actually invite them on rounds. They can round with us. So they can listen to everything we're saying and participate. And most of the, you never ignore a parent because they usually know their kids pretty well.
I think we have one more question.
Any more questions? Yeah.
Do you deal with a lot of issues with insurance?
Well, fortunately I don't, but I have a whole office staff that does. But yeah, we deal with we deal with a ton of insurance issues and insurers trying not to pay. They'll look for any reason not to pay, and that's been a real issue. And I think it's only probably going to get worse before it gets better. But don't look at all those things when you're choosing a career in medicine. It's still a great career. So I know there's probably people out there telling you there's so many issues, but it's a great career. So I appreciate your time.